And we have to contextualize that, and it really influences the way I think about what it is I do. There is a need for community-anchored services. We absolutely heard that, and we must build on relationships that exist within the communities. It is not okay for research to exist in the year 2009, 2010, 2011 on Black MSM, where the Black Gay Research Group has to go and others have to go to task with CDC, NIH, or NIMH and say, where are the Black men on your study? It makes no sense. It makes absolutely no sense. That stated, it makes no sense for us not to be at every table and to sit in isolation and say, oh, I don't want to be bothered with those groups because they're hostile to me. If I ran from every fight that was hostile to me, I wouldn't be here today. And you have got to, and part of what we have to do is find that sphere that allows us to heal those wounds. I live in isolation. I live sometime in isolation just to lick my wounds and to have them bandaged so that I can go out and do the next battle. There is a need for, and we heard references to structural and contextual interventions, and there was a point where CDC, and we use the word CDC because CDC is the public health arm for our government, but CDC writ large is what I'm talking about. For a while we talked about HIV testing as structural intervention. That is not a structural intervention. We're talking about true change. We're talking about challenging paradigms that have promulgated situations and circumstances that have very negative consequences for non-white individuals. And notice the shift in my term. I'm not talking about black folks, I'm talking about non-white individuals, because there is a presumptive new normalcy and neutrality to everything white, and we're going to talk about that in a little bit. And that is core and central to something that is not examined in the research. I task anyone in this room, here we are talking about Black MSM. How many studies can you find that have been funded on Black MSM? There are a few. People put it in the titles. How many studies have you been able to find that say white MSM, where it's a clear focus of the research? Thank you. You don't find them because there is a presumptive neutrality to being white in America. And that neutrality doesn't always fare well for us as a society grappling with the issues of race and the complexities of race as we try to untangle and disentangle what we see in front of us facing black men in this work. This is not to say we need a comparative study, but it's to hold something true and honest. And those of us who have been keeping up with the news, the Founding Fathers did not do away with slavery. Okay, let's be very clear. Those of you who haven't, check your Tea Party agenda of late, and you'll know what I'm talking about. There are things that we need to correct in the rhetoric. So those are my closing thoughts. Let's talk about getting here. Rudy, you are quite eloquent, and I'm just going to add to it a bit. There is a historical pathway for HIV/AIDS programming and research. And one of the things I admire about the LGBT community and my white colleagues who were part of ACT UP, Cry Out, and some of the early organizations that brought us there was this issue of immediate response to trauma that led to advocacy. Had it not been for men and women chaining themselves, throwing blood, and scaring the poo-poo and the bejesus out of people, there would never have been dollars flowing to begin with. So there's something to be said about the impact of trauma and advocacy and activism that lead to action. When we talk about the trajectory of HIV/AIDS programming and research in the United States, we often forget that that has been a very important historical underpinning for where we see ourselves today. We jump to the current state of research. Research utilizing the phenomenal tools of research that many of us have gained in the academy and that we don't want to let go of because they allow us to do really robust and meaningful science. But let me be clear, nobody needed to tell those folks in the early year of the epidemic, we need a study to tell you whether or not you can chain yourself to the building. They were worried about their own lives and those around them who were dying and the need for action at that moment. There has been an increasing emphasis from research to evaluation. Everybody's accountable for everything. every dollar you spend, every program activity that you do, and that emphasis has actually taken over and hijacked some of the more meaningful questions, as Greg pointed out, in terms of the saliency of the questions that can be asked, because some of those defy really neat evaluation because the questions are in fact so complex. We've gone to an agenda of greater emphasis on efficacy, effectiveness, and efficiency. And while we indeed want to make sure we get the most out of our dollars, that emphasis on efficacy and efficiency has often been cast against researchers when they propose topics. You have to have the resiliency to keep coming back, because the review body will sit there and scratch its head and say, I don't fully understand this question. How can you raise this question? It can't easily be answered. Well, if it could easily be answered, we'd have resolved the epidemic, folks. 30 years into it, we'd be over with it. Let's be clear, it's more complex than meets the eye. There's an issue of translation and dissemination. We shift to NIH. Most researchers recognize, bar the work that some people in the room have done. I keep pointing to Dr. Gale, which is a phenomenal experience to have been in our company recently on at least 3 occasions. 80% of what NIH produces sits on the shelf. 80% of what NIH produces sits on the shelf. Let's talk about return on investment. If I gave you a return on an investment of no more than 20%, you'd fire me. Hear that. You would fire me. But yet we all go running to the same source. We all go running after the same dollars, which are shrinking, to get the same return on investment. This emphasis on translation and dissemination is not paralleled in the broader structure of the funding schema. And we don't address the new needs and the new traumas as they emerge, and some of these new needs and traumas actually relate back to the historical trauma, advocacy, and activism that I started with. So it's very circular in its orientation. So some of the things that we conclude with are the very things of housing and basic human needs that have not been addressed historically, and if we don't come back to those, we're going to continue to miss the boat. There's been an increased emphasis on planning, the use of supporting data, outcomes, impact theory, cost effectiveness, behavioral science in lieu of social activism. Again, we've heard that in many different ways. The context of programming in HIV and AIDS, and again, my research and writings that I've done, which have often not been received initially with the greatest of fanfare, but then I find some of my most staunch oppositionists are citing my work, and they cite it in their proposals targeting black men, and then don't invite me to be at the table. And you know what I'm talking about. You know exactly. And it's a very interesting conundrum. But this emphasis on professionalism, the conditionality of the work we do, this is why when we talked earlier by conditionality, what I mean, oh, if you're positive, we'll give you a service. The if. There isn't an unconditional programming agenda here. And what would be an unconditional programming is if we truly had an environment where you could receive service on demand. We don't have a system where you can receive service on demand. It's predicated and conditioned on so many things, including the funding streams, interest, and their narrow slicing of what it is they're willing to finance. I don't live in that kind of compartmental life. When I show up, you got to take all of me, like it or not. And when you don't take all of me, there is a consequence for that. I'm not coming back to you. Or if I come back to you, I'm only bringing that piece of me that you're willing to deal with, which means you absolutely cannot get the whole picture of me, and you are in no way capable of providing a service to me that meets my totality. Often we force foreign tools, concepts, and methods on programming. Evidence-based interventions have their utility. But let's be clear, evidence-based interventions, as were pointed out, are often created in certain environments that really don't test their ability to roll out in terms of broad spectrum application. If we don't have the broad spectrum application and understand these issues, we are not going to be able to put out a fire in an epidemic that we say is a state of emergency for black individuals. And oftentimes our interventions front community members. Those of you who don't understand that language, we play them for dirt. Okay, we bring them to the table, we pay them as peer educators, we utilize the hell out of them, and then we dismiss them. This is one perspective on HIV prevention for black men who have sex with men and men who have sex with women. And we've heard it last week at the NASM meeting. It's a penis-focused prevention agenda. A penis-focused prevention agenda. And you know what? While, you know, brothers got it going on, in many ways, everything about us doesn't have to be penile-focused. Everything about us doesn't have to be penile-focused. However, in the history of the United States, the Mandingo agenda has resulted in a lot of this occurring. And we really do have to own that, and that's why I use the terminology that I use very carefully when I say non-white, when I say non-heterosexual, or when I say non-gay. Because as opposed to focusing on the individual that is receiving the oppression, I want to turn the lens, as John Hope Franklin would say, the mirror to you, the mirror to America. I want you to see your pathology in the work you do, as opposed to seeing the manifestation of the pathology in the lives of the men that we're trying to study. And so we really do have to move beyond this singular focus on genitalia as a prevention method. Because I have a brain, I have brawn, I have heart, I have soul, and I have family. Within our contextual and structural factors, we must address, as I said, the poverty, the housing, the homelessness, the criminal justice. We have to address issues of racism and the presumptive rationality of racial constructs, including the manifestations as they exist in the public health system. We have to confront heterosexism and homophobia. Again, I said I would not focus on the data, but if you were to, almost all of this is in the writings that I've done, and they're easily accessible, but I wanted to make the points that I want to make in the time that I have available to me. We did talk earlier about not, when we heard earlier from Marlon, you were talking about the ball house community and the complexity of the lives. You and I have a slightly different way of articulating it, but the sexual self, we don't address the full sexual self of black men. Not that we address it for anybody, really, but I'm focusing on the black men because that's what I have the podium to do. There is a biological reality, and we have to make sure that our men understand that biological reality and that we're actually looking at it. We don't know what is the long-term effect of stress on one's sense of arousal. There is a physiological relationship between sustained stress and things that happen within your body and may affect the way your body functions. So we have to understand the biology. There is a relationship and a part of your sexual self that is about orientation. And I always like to attribute this to a very dear friend of mine when we were post-college and living in Chicago. And she said, you know, the way I understood orientation was like this. I didn't know why I liked sliding down banisters when I was a little girl, but I liked sliding down banisters. And so that made sense to me. It was before we gave language to it. See, some of you got it. The rest of you, lean over and tell a friend later. All right. You have to understand that there is a part of us that is purely about things that we like that don't have a negative connotation to it, but unfortunately society and social systems ultimately strip that away from us as we develop an identity. Another way of thinking about this is when kids are young, second, 2-year, 3-year, 4-year-old, you go to pre-K schools and you look who's holding each other's hands. It's little boys holding little boys' hands. If you tell people get with your best friend, it's very often going to be somebody of the same gender. You go to a basketball court or of 16-year-olds and say, hold your best friend's hand, they would rather cut their hands off than grab that same individual. And the question becomes, what do we do to people in those 10 years to remove them from the capacity to be able to share that level of intimacy and to replace it with a social identity that actually does destruction to both heterosexual and homosexual relationships? Because then, even in a heterosexual relationship, the only way one understands to interact with their partner is through sexual conquering.